All right, this is a fracture that we all see frequently. This is more of a typical boxer's pattern fracture, distal metacarpal neck of the fifth. Most of these are going to be treated non-operatively. This one I would probably treat non-operatively, but when they come in more displaced, especially if they're flexed down more than about 40 degrees, I have a long discussion with the patient regarding the pros and cons of surgery. A lot of patients do not want the bump that's going to result from a bit of a flexed union there. Other times, simply allowing the patient to use their hand quicker is very attractive to them. I've got athletes, MMA fighters, who have used this technique and have been able to return to sports much quicker, to return to their normal activities. So we'll start this center of the head as always. Try to the dorsal third, and I'm applying volar traction here with my other side of my hand. Yeah. So I'm happy with the dorsal third placement there. I'm happy with the center of the head. And now as I hold manual reduction, I'm going to advance the K-wire down the shaft. Yeah, and it can take a few passes, but far fewer than when you're trying to do cross pinning. You need to spend some time establishing the proper starting point. But once that starting point is established, advancing the nail itself takes that typical deformity, which is a flexion type deformity, brings it into full extension. And so really with no maneuvering of my own, the nail itself will just force this into a neutral alignment. I'm happy with that length, so I'm going to go ahead and take my measurement, place the guide on the metacarpal head and confirm the position on C-arm. This is measuring a size 40, about a 46. This is a distal third fracture, so I will insert a size 40. I have plenty of room approximately there. So as always, holding the fracture here. Ah, yeah, good point. Okay, we have an oblique fracture here, bit of an oblique fracture, and a headless compression screw in this type of fracture pattern always sets patients up for potential shortening of the metacarpal and frustration on the part of the surgeon. So I don't really worry about compressing this at all. This is a non-compressive screw, so I just advance right across there. And you can see there's really no shortening at all so far. That illustrates the obliquity of the fracture. Getting some good cortical purchase here. Okay. To try to illustrate that oblique fracture again, you can still see a little bit of a gap, less than a millimeter, but enough to know that I have not shortened the bone, which is my goal in this case. So these are three separate fracture patterns going from very unstable on that ring finger to a comminuted neck fracture on the middle, and then a typical boxer's type fracture on the small finger. With all of these, I'm very confident in range of motion. I'll move these extensively. Almost trying to displace those fractures, and you can see the rigid stability of that intramedullary fixation. There's no way I would try that type of stress on K-wires. The other thing I was getting at before when I mentioned the fact that this nail almost self-reduces the fracture, when cross pinning with K-wires, it's difficult to find the starting point and to get the starting point correct on that collateral recess. So much attention, at least in my hands, is directed towards that by the time I get my starting point and get the K-wires across, often I'll take this x-ray and you'll see flexion. Maybe not significant, maybe 20, 30 degrees of flexion at the fracture site, but there will be some. And you're certainly not inclined to go start all over. You don't have to worry about that in this. Advancement of that nail just pulls that distal fragment back up into extension and you end up with a neutral alignment.